Great. Thank you again for inviting me to this great symposium, and thank you, Dr. Tatal, for a really fantastic overview and pretty much setting stage for me to talk about molecular testing in perioperative restratification. My disclosures. As Dr. Tatal just discussed with you, we are talking about currently we are operating using the 2015 risk of structural disease recurrence stratification that was in the previous guidelines, and Dr. Tatal indeed sort of pretty much put it together and in the previous edition. So, and we, as he already mentioned, indeed, at that time, we incorporated some of the molecular markers into this risk of structural disease recurrence stratification. Also, obviously, this remains largely a post-operative stratification, which requires knowing pathology, requires extrathyroidal extension, and other parameters, vascular invasion, and so on and so forth, to predict the risk of structural disease recurrence. And in my talk, I want to bring the following couple questions. Can molecular markers provide robust restratification of thyroid cancer independent on pathology? And if yes, then can this be achieved preoperatively? And I want to stress robust, I mean, not just sort of like Dr. Tatal mentioned, just, you know, one or two anecdotal cases, but really robust restratification that will in no way substitute all perioperative restratification, but just add additional valuable information before the patient undergoes thyroid resection. I want to start with this case, which to me was very illustrative and really set a stage for me for trying to really understand better how molecular markers can be used for restratification. This is a paper coming from, I believe, from Sweden, where they looked at TERT mutations and other molecular events in follicular adenomas and atypical follicular adenomas. And you see, this is a table where most of these follicular adenomas, they have no alterations, and there is one, this FT821, that had RAS mutations and TERT mutation. And I just enlarged this case from the table for you to look at. And so what we can see that patient had, like I said, RAS and TERT mutation, had a diagnosis of follicular thyroid adenoma, and eventually developed disease recurrence and died of disease. So obviously, this is a situation when pathology was much less predictive of the outcome than molecular testing if it would be done before surgery. And I am very far from saying that all follicular adenomas, in no way I'm trying to say, I'm saying that follicular adenomas, we have to be careful and we have to observe these patients and follow these patients and so on and so forth. Absolutely not. But what I'm saying is that we have today molecular tools that can help us to make our job easier and really to identify that a very, very small proportion of tumors that masquerade as benign or very low risk, in reality have potential to kill the patient. Looking overall at the evolution of the understanding of use of molecular markers for cancer risk assessment, I want to say that it started in just soon after discovery of BRAF V600E mutation in thyroid cancer. It was around 2005, 2007, when practically all studies that looked at the prevalence and clinical features of patients with BRAF mutations, they saw observe that the behavior of these tumors was a little more aggressive, and disease-free survival was less high than in BRAF V600E negative tumors. It was an interesting, it was exciting observation, but I think that it was taken too far. And some of us, like this paper published in JAMA with the title Association between BRAF V600 mutation and mortality in patients with PTC, in a good journal. And obviously, this sort of such studies, such sort of statements that BRAF is a sort of death gene and so on and so forth, obviously cause a big sort of, backsplash and disbelief in the field, because we all know that BRAF is very common mutation in thyroid cancer. It's 40, 50, 60% of all tumors have BRAF. So to say that BRAF is associated with mortality was not correct, was not right. And this is again something that I think throw this field few years back because of the general disbelief and a sort of rejection to use of molecular markers for risk stratification. But I think that now we are back on track. So first of all, a little bit more knowledge few years later clearly showed, and this is a study from our institution by Lin Yip, who looked at 1,500 patients that were all genotyped, mostly with differentiated thyroid cancers, and clearly showing that RAS is a low-risk molecular markers, and BRAF is just an intermediate risk, is 5 to 8%. So this was before the TERT was really discovered and understood, but it's already sort of started to set the correct correlations between molecular markers, including BRAF and prognosis. So BRAF as a single marker is just a marker of intermediate risk, definitely not high risk thyroid cancer. So low risk and intermediate risk. But really situation started to change after the discovery of TERT mutation and understanding that this is a true marker of more aggressive behavior of thyroid cancer. This was one of the first studies published in JCM from University of Porto, close to 500 patients, clearly showing that TERT mutant and TERT wild type patients have very different, not only disease-free survival, but also cumulative survival. This was replicated in other studies, like this report from South Korea on 550 differentiated, I want to stress, differentiated thyroid cancer, showing that even the ATA high-risk group can be further classified by TERT status into tumors that are closer to intermediate and those that have really sort of a high probability of tumor recurrence. Same for stage 3, 4. This is a previous AJCC restratification, but still sort of again showing in the same way that that addition of the TERT marker would provide much more granular prediction of risk for recurrence in these patients. And finally, we come to the current state of knowledge and current understanding. And this is now, when we look at the data based on a more broad genotyping, when we don't look only for TERT or only for BRAF or only for RAS. Now we started to understand that what really was driving as this a high risk sort of behavior of BRAF positive tumors. It was the combination of BRAF and TERT. Now this has been replicated in multiple studies, showing that really, again, to summarize, RAS-like thyroid cancers that don't have any other late hits such as TERT are low risk, and this is disease-free survival. BRAF and BRAF-like tumors are intermediate risk, and combination of RAS plus TERT and BRAF plus TERT is high risk. So I also want to mention, to bring your attention to this graph. This is third only. It's still sort of, the risk of cancer is somewhat higher than the intermediate risk, but not as high when third is found in combination with other early drivers, as we discussed earlier. This is a reanalysis of the TCGA data on about 400 PTCs from different sites, showing very similar, actually remarkably similar results. Alone, BRAF and are low risk or intermediate risk. Third is somewhere in between, but third plus BRAF and RAS is a high risk for disease recurrence. So it's not only disease recurrence, and Dr. Tuttle sort of made a very, very good sort of point and very clearly stated that we also need to think about the survival, disease-specific survival. And now we can again talk about the real findings and more sort of clinically meaningful findings. Even when we talk about the disease survival, the presence of BRAF and TERT has about 9-fold increased risk of patients' death from thyroid cancer. So finally, this culminated in this meta-analysis published in 2020 based on more than 8,000 patients with thyroid cancer, meta-analysis of 27 studies, showing where they look at lymph node mets, distant mets, tumor recurrence, and mortalities, basically showing that the finding of TERT mutation alone has statistically significant association with the probability of disease of distant metastasis and disease recurrence, but not statistically significant association with tumor mortality. Whereas BRAF plus TERT and RAS plus TERT combination across this very large cohort of patients show clear association with the distant metastasis, tumor recurrence, and tumor-related mortality. What about Hürtel cell carcinomas? As we discussed before, that these tumors have quite different molecular landscape, particularly with respect to early events, early driver events. We know that these tumors are mostly driven by multiple copy number alterations. So now the prognostic significance of TERT has been clearly showed in these tumors too. This is one of the studies from Memorial Sloan Kettering showing that when we look at widely invasive and minimally invasive Hürtel cell carcinoma, there is a significantly higher presence of TERT mutation in this widely invasive tumors. Another study, this is another study from MGH showing that also TP53 is another late mutation that is relatively common in widely invasive Hürtel cell carcinomas and is as such likely to be associated with tumor prognosis. So what finally today in 2022, what can we say? We can say that if we look at the ATA risk of structural disease recurrence stratification, we can match it with specific genetic profiles. These profiles are RAS-like mutations associated with low-risk cancer, BRAF-like mutation associated with intermediate risk, and combination of BRAF plus TERT, RAS plus TERT, or BRAF and RAS like mutations in combination with other late events such as TP53, PIK3CA, or AKT are really marked tumors that are likely to be of high risk for recurrence. So can these predictions be validated in specific studies? And the answer is yes, at least in retrospective studies. This is one of the recent studies published from Lin Yip and colleagues from our institution, where they look at patients with distant metastasis. I mean, we've debated for some time, really, sort of what to take, what to accept as an unequivocal evidence for tumor-aggressive behavior. We were discussing possibilities also of recurrence, but local recurrence, as you can know, is a recurrence or persistent disease, biochemical recurrence, and we decided we go only for distant metastasis as an evidence for aggressive behavior of differentiated thyroid cancer. And all tumors were well differentiated. All poorly diffs and anaplastics were excluded. So it was a cohort of about 60 patients with differentiated thyroid cancer that was propensity matched with cancers, with differentiated thyroid cancers that after at least 5 years of follow-up didn't have evidence of biochemical and structural recurrence. So group of DTCs with distant and without distant metastasis. What was found? That there was no difference between the groups with respect to early driver mutations. Prevalence of BRAF, prevalence of RAS, fusions was not statistically significant. Actually, I want to say that in terms of fusions, there was a little bit of a tendency to have a higher probability of retin and TRK fusions, but it was not statistically significant. But when we look at the late events, again, third, TP53, PIK3CA, which were present in the tumors driven by early mutations, early drivers, there was a dramatic and statistically significant difference between the two groups. So about the odds ratio was 11.4, so close to 12-fold increase the probability of distant metastasis when a patient had third or another late hit as a part of genotypic results identified in these tumors. And when we looked at the grouping as a low, intermediate, and high risk molecular group, indeed we did see a strong correlation with tumors that develop distant metastasis and not. So trying to extrapolate this data on clinical practice in the clinical range of distant mets, which is about between 5 and 10% in differentiated thyroid cancer, the results of the study shows that if the tumor has a low risk molecular profile, which is again RAS mutations alone, but I want to stress that RAS, if the small panels or single markers will not work here because RAS alone and RAS plus TERT, these are two completely different diseases. So when we are talking about RAS alone genotype, these tumors in this study should expect to have a 5 years risk of distant metastasis at less than 1%, between 0.2 and 0.4%. For intermediate risk tumors, which are BRAF-like tumors, it's between 5 and 10%, and for high risk tumors, between 20 and 35%. So in a sense, this study provides additional evidence that we can use molecular profilings to pretty much recapitulate the expected probability of disease recurrence, or let's say distant metastasis, 5-year risk of distant metastasis, conferred by low, intermediate, and high ATA risk classification. So this study was performed on surgical material. So the question is, does this work in FNA sample? Can we predict it preoperatively if there's a purpose of our sort of approach? This is a study from UCLA. There were 80 patients with Bethesda 3-4 nodules, positive for molecular testing and surgical outcomes, and indeed showing that findings of TP53 mutations, particularly in combination with BRAF, but not necessarily, also with RAS, were definitely marked the tumors with more aggressive histology or clinical presentation. In this cohort, there were 5 patients that would be classified into a high-risk group. Again, most of them is TERT plus RAS or plus BRAF, P53 plus AFNX or TERT only. I mean, among them, there were 2 poorly differentiated carcinomas, and all other were at least cancers, and some of them had ATA high risk after resection. So the authors suggest that individualized patient management, including extent of surgery, should be considered based on specific genetic alterations found in cytologically indeterminate thyroid nodules. So another question that we can discuss is, are high-risk thyroid cancers large and clinically apparent? Sort of this is something that, and for that reason, really, based on clinical findings only, we are able to provide a pretty highly reliable risk stratification. Obviously, in most cases, yes, but not in all cases. This is a study from University of Utah of a series of 8 patients presented with symptomatic bone metastasis from unknown primary. So all patients had typically multiple bone mets with unknown primary tumors. And on biopsy, it was found to be thyroid cancer, and 7 cases it was PTC, and 1 was follicular variant, and 1 was tall cell PTC. This is the genetic profile of these tumors, but what is interesting is that 2 of these tumors were under 1 cm PTCs, 0.4 and 0.6 cm. But both of these tumors had an aggressive molecular profile, either TERT plus RAS plus copy number alterations, or TERT alone. So really, again, what I think that this data, this study shows that we would be able to predict and to fish out, to identify granted a small proportion of tumors that have rather indolent pathology and have rather indolent nodule, small nodule size, and perhaps not so much aggressive clinical presentation at the beginning, but have a potential to develop disease, widely metastatic disease. So then the question is, to come in the full circle, how common is this high-risk molecular profile? Because again, remember the story of BRAF, the early days of BRAF. If we find this findings very often, something would be wrong, because we know that there is only a small proportion of differentiated thyroid cancers that really are bad players that can hurt patients. So this is a study of Bethesda 3 and 4 thyroid nodules, preoperative analysis, multicenter study, showing that about 2% of mutation-positive thyroid nodules had high-risk mutations, TERT on TP53. So these are good data, because we know that we do expect that it should be a very small proportion of these nodules, of these tumors, that would have aggressive clinical behavior. So what about just the overall series of papillary carcinomas? This is a consecutive non-selected series of 500 papillary carcinomas, tumors that have BRAF TERT or BRAF P53, BRAF PIK3CA mutations. You can see they are located here. Every column represents 1 tumor. You see BRAF and TERT, and some of them P53 and PIK3CA. So this is a well-differentiated thyroid cancer. So if we have a well-differentiated thyroid cancer that has combination, let's say, of BRAF or RAS plus TERT plus PIK3CA or TP53 mutations, so these tumors, remember Dr. Cabania's presentation, this is a profile of anaplastic carcinoma or poorly differentiated carcinoma. So even if these tumors appear to have a relatively low risk pathology, even if these tumors seems to be low risk at the time of presentation, we probably have to consider these tumors as a high risk tumors and manage this patient accordingly. So how often this can be seen? In about 10% of papillary thyroid carcinomas. I think that this is a comforting thought, because now it fits common sense. It fits what we see in clinic. It's not 50%, it's not 40%, not 30%. It's approximately 10% of PTCs, and I would extrapolate this data on all differentiated thyroid cancers that have this aggressive molecular profiles that is likely to behave in a clinically aggressive way. But to the point that Dr. Tuttle, stated in his talk, we still need more prospective data. We need to be sure that the identifying and treating these patients more aggressively would make difference in their long-term survival. So obviously we need prospective data, and one of the important studies that we are waiting for completion is currently going prospective study at University of Pittsburgh. This is a clinical trial of use of molecular markers to direct extent of thyroidectomy. Dr. Lin Yip is a PI in the study. Study is focused on patients that have Bethesda 5 and 6 thyroid FNAs, so nodules that are most likely to be cancers, to be probably papillary carcinomas, size between 1 and 4 cm. The rationale is that under 1 cm, this is obviously a low risk. In the vast majority of cases, more than 4 cm, we know how to treat them, at least at our institutions are treated with total thyroidectomy, but this is a group between 1 and 4 cm. That's where the current ATA guidelines recommend managing based on the risk, and how to evaluate the risk preoperatively is not entirely clear. So this study patients have molecular testing, and depends on the high versus low or intermediate molecular risk signature. They offered either lobectomy or total thyroidectomy. What is going to be an outcome considered? Booked as an outcome for this study is the rate of conversion from lobectomy to total thyroidectomy. That will be a measure of how molecular testing can predict correct preoperative molecular testing can predict extent of surgery, correct extent of surgery. This is obviously only one of the study. We also need study for treatment, different treatment modalities in this patient. But I think that, really this will be the first prospective study of application of molecular testing and impact on the surgical management of these patients. The targeted recruitment is 100 patients, and last time I checked, we have about 80 patients, and now it becomes a multi-center study. So we really hope that by the end of the year, the study will be completed and we'll know the result. So to summarize, I hope that I convince you that we have abundant retrospective data on molecular marker association with tumor recurrence, distant metastasis, and even overall survival. We have rapidly increasing number of studies on cancer risk stratification in FNA samples, and I also want to say that I know at least of 2 studies that will be published this year. However, we need results of prospective trials, which are pending, to really start to develop a significant sort of level of comfort in start managing patients. Well, not start, but let me rephrase, to utilize, to add the molecular profiles to the clinical picture in informing the management of patients with thyroid cancer. Thank you again for your attention, and I stop at this time.